Moshi Moshi. Let's talk about the future. I'm Kristy Bird MaKieve, and welcome to Evergood Podcast, where we talk about all things healthcare education innovation. Today, I'm very excited to have a special guest, Dr. Jonathan Updike, who I happen to know. We worked together since 2019. He is the clinical assistant professor at Stanford University's Psychiatry and Behavioral Health Sciences Department. I think I got that name right. And a child and adolescent psychiatrist, board certified. And I had the pleasure of getting to know Dr. Updike in 2019 when he joined with Dr. Stephen Adelsheim, the residency task force that we were establishing to then develop a psychiatry residency through Healthy Rural California. But as of the last 6 months or so, we've been talking about Wyoming and the need for more medical education. So, why don't I think I'm sure I missed some other things in your introduction. So, is there anything you wanted to?
Sure. No, thank you. So kind of you to introduce me, Christy. Um, Feel free to call me John. I it's not too random to connect to Wyoming. I'm multiple generations from there. My family still lives there and still care about the state's trajectory, having been involved despite having left the state in 2013 to attend med school in New York, get a degree in public health in Baltimore, and then come to the Bay Area in 2018. And as Christy mentioned, be able to help along with a lot of her efforts in expanding healthcare education and healthcare delivery in rural places in California and maybe take that more broadly. We had the opportunity to attend the National Rural Health Association's different conferences and learn a bit more about how rural health is transforming over the past number of years. And I haven't been in a little bit, and I'm sure they have plenty to say. I also continue to stay on as a board member of Healthy Rural California and continue as a board member of empowering the next generations to advance and grow the economy, or Engage, which is a 501c3 I founded back in 2018 under former Wyoming Governor Matt Mead in an effort to incorporate young people with long-term strategic planning for economic development, because we know that the young people will inherit that economy and may benefit from having a voice in what they'll get and help shape in it. And as we all know, healthcare is really important economically in terms of the healthcare that's provided, as well as the jobs and economic boost within the communities, as well as having a robust infrastructure for other industries to develop.
Very
Um,
well said. Yeah.
I don't know, rambly, but maybe I got the message across.
No, no, it wasn't rambly at all. Uh, I love that you have connected that economic development with healthcare workforce development, because the two really do go hand in hand. And about a month ago, I think we met to work with Harvard's program to do economic development, Path to Prosperity, I think it's called, in Wyoming. And your colleague Eric wasn't able to join us today, but maybe that's another podcast we can do in the new year. Um, but yes, when you the first thing you think about when you're talking about economic development is higher paid salaries, and salary and jobs that are sustainable. And to me, that's always been healthcare. It's kind of they go hand in hand. And yes, we did go to the National Rural Health Conference in 2023, I think. 2024. I learned a ton
Mhm.
and I still follow them even though I'm not working in that space right now. But yeah.
Mhm. Yeah.
Uh, so go ahead.
No, I was just gonna say, I think healthcare, economic policy can all have a lot of really strong political bents and approaches and outcomes, and the like. And I guess I follow outcomes and facts and try to keep that in mind with what's effective for economic development and effective for the provision of healthcare, and learning about the Camp Fire, the in Northern California, the subsequent community needs assessment, the results indicating a high need for psychiatric care and mental health care, and then the subsequent steps to say, okay, how do we get more psychiatric providers and mental health care here if that's the biggest need we have? And looking at the evidence, seeing, well, gotta create the training program. And when people train in a location, they tend to stay there afterwards. And it's so much more expensive and difficult to recruit people from elsewhere if you don't have a program there. But then being undaunted by the lack of existing medical education, postgraduate medical education infrastructure, as well as perhaps a tertiary care hospital with multiple specialties that could help facilitate that training, but instead saying, this is what we need, how do we do it, rather than we can't do it because X, Y, or Z. And I imagine many places like Wyoming can benefit with that intentional, how do we make it happen approach, even with the many obstacles that folks in rural places face, and every rural place is different. But I wanted to also note, I'm influenced, didn't read the full book, but Amartya Sen wrote um, Development as Freedom. And that was back in the 90s, basically asserting that unless you have the tangible option, it doesn't exist as a possibility. So someone in a
Yes.
rural place could technically become a psychiatrist, go elsewhere, do their training, come back. And it's harder if there aren't local, more accessible, financially feasible social supports, cultural encouragement that enable that trajectory much more likely. And development toward the different possibilities to make it easier and more accessible, I think, is the heart of how I might approach healthcare, healthcare education, economic development. And I don't know if you'd come across that, but just ideologically speaking, that resonated with me.
Yeah. Well, for me, for like just in medicine, the medical education journey is so long, and when you have to leave for a certain number of years in a time when you're developing your life, you're going to start setting down roots somewhere along that journey as opposed to where you come from. Then getting them those physicians back to, say, Wyoming, is even that much more difficult. On that journey, you might be meeting somebody that is then your partner for the rest of your life. So you're setting down roots with that person, and then it's up to them whether they can move too. So then you're like the odds, the longer you go, like so each year through that education journey, the farther away you get from going back to the spot. And We haven't said it yet, I don't think, but Wyoming has zero medical schools. There are some programs called like WWAMI that are with the other states neighboring, but still, they are still going out of Wyoming to get that education and thus not as likely to come back. And I think there's a really important part of that journey, and that's true for all healthcare, social work as well, is that you have these really intensive clinical requirements to finish medical school, right? The core clerkships in year three, and then into the residency programs, which are no less than 3 years and could be as long as 5 years. And then people like you go into a fellowship, which is even longer. And so then you're actually married to a clinic. And if that, and I think you said this earlier, if you don't have that clinical experience back in Wyoming, then you're not going to be able to make that transition for your career back to Wyoming. So yes, it's a very complex issue, but why you and I have been in these discussions for many years, which is how do we make medical education happen where it is needed no, most. So you have since 2019 talked to me about more medical education being needed in Wyoming, and I think it was this past 6 months that you really came to like let's make a medical school happen.
Sort of, yeah. I had originally written an opinion piece, pie in the sky, for a large newspaper in Wyoming discussing aspiration for a medical school back, I think, in 2021 or 2022, in part to help move the Overton window, so to speak, make more real what could be possible, at least have those discussions more in the open, and have heard excitement about the possibility, not only for healthcare reasons, for economic development reasons, and for adjacent economic expansion reasons, but also to help people stay closer. And I know there are a myriad of challenges at each level. And I hope we can have the conversation by pausing, saying, and instead of hurriedly following it with a but and a reason why we can't.
But
Rather, how do we make this happen in spite of obstacles? Because it's tremendously important that we have physicians train the communities that they practice and want to stay in those communities once they're done training. As we mentioned earlier, folks are more likely to stay. And I think that's really important for psychiatry, at least, because the legal parameters each psychiatrist abides by differs state to state. In
right.
California, there are county by county, and that complicates things even a little bit. But not training in Wyoming means I am not as readily familiar with the framework for emergency and voluntary evaluation as I might be here. They're similar, but not quite the same. And it would take some time to adjust and have to learn along the way, which is extra effort. Some folks may be excited to do, may not. I have a medical license in Wyoming with the aspiration to practice more there. In the meanwhile, I'm over busy,
Yeah.
over committed in the various community settings here, both Stanford, in the Bay Area, and then with telepsychiatry to Northern California. I had something else. It's gone.
Well, right. You were going to say that, that each year that goes by, probably the chances of you returning to Wyoming, even though you are licensed to provide care there, like each year is probably getting more and more distant. Uh,
It's harder. Just talking about having the fortune to invest in a home there with my family to help them with their work and maybe have a place I could crash if I could make some opportunities happen. And keeping that as open as possible there in Gillette, though. And it's time spent on the ground in these communities. I can't just, I don't know,
yeah.
puppeteer from California and pretend like I know what I'm doing or am connecting. I'm looking to get back to boots on the ground and the in-person conversations and connections, relationships and networks that are so vital toward building momentum, coalitions, and building progress by understanding people where they are, how they live, why they live, and not by a telescopic lens.
Mm. Very, very well said. Yeah. I
I,
think
I
oh, sorry.
well, no, I was just going to say, like, in going back, wanted to also maybe remind listeners who might not be so fluent with the education pathway for a psychiatrist, much less a child and adolescent psychiatrist, is graduating from 4-year college with a bachelor's, taking a test, and being accepted to medical school, which then would be the 4 years, and then the 3 years of residency for someone fast tracking into child with two. And I think what that's minimum 13 years. And if your state doesn't have a med school, much less residency program, much less fellowship program, that's a long time to spend away from home, especially if you don't have family elsewhere or networks elsewhere. And that's if you have the privilege of coming back to visit family, financially, logistically, emotionally. I think the state of Wyoming has done a great job with what it has in its partnership with the University of Washington and the WWAMI program in increasing the amount of time that's available for medical students to learn in Wyoming while balancing multiple um, compelling challenges in terms of the number of medical students that could be trained per year and the clinical knowledge that could be gained in Seattle, which is a tremendous asset, and the return for a prescribed period of time to Wyoming is 3 years for WWAMI, and Witchy, I believe, is also 3 years with other medical schools in the West, and many rural places do similar things with requiring students who participate in these programs to return for a period of time or pay more in terms of tuition, education fees. And I think as someone who had contemplated, well, my debt could be, 6 figures or it could be 3 times 6 figures. That's a pretty weighty decision while you have an 11, 13-year trajectory in front of you. And we know, at least for online data, the WWAMI program has about 2/3 of folks who do return, which is great. And there's a third of people who aren't coming back. And I'm wondering how many aren't coming back in part because of that restriction. I think it's a great opportunity to practice in Wyoming, for instance, and I would like to. And I feel really fortunate in having the chance to be on faculty at Stanford and do community mental health here too. And I wouldn't have had that chance if I went back to Wyoming.
Right.
And I think rural medical education, graduate education will benefit from improved partnerships and collaborations for the flexibility that people want if they want to practice on the coast but have access to resources, colleagues, um, from places in more urban areas or better resourced financially, institutionally. It may take more collaboration, administration, and yet I think the benefit could be worth it. We just don't know and can't quantify that so easily. Sorry, that was again more ramble, and hope that helped add context.
No, I appreciate that. I think we're still growing this podcast, and so it's hard to predict who will actually be listening now and in the next year or so. But I do think these will be helpful for people making those decisions in healthcare to, just kind of guide their own life. They're huge decisions. I think you just articulated it very, very well that, it's not like you just decide to become a doctor and then, everything works out. There's so many decisions within the MDDO world. Like, what do you specialize in, and where do you get to go if you do have to choose and you don't always get your choice, but there's so many decision points and you know and I think that there's so much work that still has to be done in terms of policy and resources to help people make those decisions and encourage them to go into rural areas because it's not the first choice. And it is also the infrastructure, right? If all of the medical schools are in larger urban areas or with more population, then the rural areas are already automatically not going to have that kind of roadway, right? The path back to having the physicians finishing their degrees and their residencies and then heading back to the areas where they're actually needed the most. So lots that can be done. I think you were a good voice for that.
Sure. I guess in response to some of that, I think it's important to note a few things. The percentage of rural applicants to medical schools has consistently been declining
Mm.
over the past number of years per, I believe it's a health uh, resources article back in 2019, a whole issue dedicated to rural health that was tremendously insightful and that I cite a lot. And the percentage of um, BIPOC individuals from rural places who, across the board, have the worst all around mortality health outcomes in terms of urban versus rural versus other groups is even less than one would expect from just being rural. And so rural folks are about 20% of the population and maybe 5% of med school applicants. And we know that rural places aren't uniformly white, but the BIPOC rural applicants are less than, I think it was 1% or 0.5% of all med school applicants, even though they would occupy about, I don't know, more like 10 to 15% of the US population. And with these trends, we would have to dramatically increase targeted recruitment of both white and BIPOC rural folks in order for those entering med school to be representative of the population that the US has.
Right.
Furthermore, there's an underrepresentation of training programs in rural areas. And of the very few that were listed among many specialties, a majority of them had put urban addresses for their clinical sites, which makes it maybe not quite the rural training or experience you might have in practice. And of course, it's a balance to note. Um, but the opportunities and those who are able to access them are decreasing for folks in rural areas across different backgrounds.
Right. I always believe that if you see what you could be, then you're more likely to go for that. And I think let's just say, without having a medical school in the state of Wyoming, that people can then see and be inspired by and interact with, then you're definitely not reaching those youth in that state. Um, yeah, it's that's not a good trend at all to go downward.
No. I also hope to quickly highlight perhaps a different trend that's happening at the opposite end in medical schools that began more as I graduated and in the years subsequently, that private, well-resourced medical schools are now able to offer debt-free medical education, which is a pretty compelling opportunity. And I would argue more compelling than restriction to a geographic practice
Yeah.
area following training, and and I anticipate would lure people away from their training programs, especially if they are rural and decreasingly represented in a way like I was. I didn't have quite the full debt-free part, but that came later, and excited for the folks who have from Wyoming, South Dakota that I know, gone to Columbia and gotten debt-free education without feeling obligated to practice anything in particular or go someplace. And I imagine those significant investments in a flexible medical education and graduate medical education will allow people to pursue what they like without feeling constrained.
Yeah, brilliant. There was one thing that you said a little bit earlier about how um, so folks have to list where they did their clinical rotations, and they're often listing urban zip codes or addresses. That is something that we really struggled with in Chico, which is that Butte County is rural, but Chico itself and many of the zip codes, and especially the hospital there, are in urban zip codes. And so the way that CMS categorizes rural versus urban is actually quite faulty because you know, this particular hospital in Chico has this urban zip code, but like they're serving, nine different counties, some of them frontier. So doesn't that catchment area of where the patients come from count more than where the actual Of course, the hospital is going to be listed in a urban zip code because that's why would you build a hospital with 167 beds in any place that isn't urban. Like you have, it's a, that's one of the things that we should advocate for to change.
Oh, sure. I think that's a seemingly straightforward complexity that maybe folks outside of the rural health realm um, don't readily appreciate. And that is oftentimes rural is defined as not urban. And gosh, I've got a presentation where I think I list 8 or 9 different definitions for rural, which you have to understand and be aware of in terms of grant applications to different agencies and just the administrative toll it takes determining eligibility and how funds can be allocated is enormous, and often have those resources better in urban areas, less in rural, and rural places often have fewer individuals trained or capable of managing the complex administrative work relative to urban counterparts, and then fewer people to do the work. And
Yes, yes.
administrative burden in urban places is huge, and it's large in rural places with fewer people to tackle it. And it has been a huge problem for Medicaid and CMS in smaller places, at least from my understanding. Thankfully, I'm more clinical and don't have to do the programming work behind the scenes, and I'm tremendously helpful and grateful for the folks that are helpful for that.
Yeah. Yes, just from my time working with the folks up north of California, that uh, the small critical access hospitals have, it's almost impossible to keep them staffed and following all of the regulations as well. Um, yeah,
Yeah.
but
Sorry, I know
really,
we're getting away.
no, no, it's okay. Well, I do want to be respectful of your time, and we have about 7 minutes. So, what did we want to go back to Wyoming? I actually would love for you to describe the work that you've done as a resident and fellow at Stanford, where you led the development of some community clinics in Oakland, if I remember.
Sort of, yeah. I guess a few different maybe highlights, glory days to review. Because of my work with Engage in Wyoming, I was contacted by the US Surgeon General's office in 2020 to coordinate what was going to be an in-person visit for the Surgeon General there in Wyoming, because their office had a strong mandate to visit every United States state. And they had really liked the community health and economic prosperity lens that we had with Engage and continued to develop. Then the pandemic hit, shifted things
Yeah.
around. And we were able to facilitate a virtual visit with the Surgeon General to Wyoming through Leadership Wyoming. In terms of other work I did in residency, well, that was also the Surgeon General's first visit to Wyoming, and feel fortunate to be able to have made that happen with the resources we did at the time. Um, as a chief resident, I helped recruit our first community track residents who are embedded in more community clinic settings that uh, require perhaps more administrative partnership maintenance development than, say, a solely clinical through the institution. So that was exciting. I had the opportunity to be the community track fellow for Stanford's Child and Adolescent Fellowship from 2022 to 2024, and have helped build partnerships with San Mateo County, which has their own community-based, county-based psychiatry residency program, and felt helpful connecting their expertise with Healthy Rural California's another community-based, largely county supported structured residency program, as well as advance more integrated care within Stanford by connecting pediatrics, internal medicine, and psychiatry a little bit more broadly. Tried to get some health policy work going. Didn't quite move things along as far there as I would have liked. And still getting emails today about improving collaborations between San Mateo County, Stanford, and ALCOVE, which is Integrated Youth Mental Health, through work pioneered by Dr. Steve Adelsheim, borrowing from the Headspace model in Australia, not the app, but youth led, meaning a youth advisory group helps develop, inform, and lead the mental health care, physical health, supported education, employment, substance use, family support, peer support, those 6 service streams integrated in a brick and mortar community-based setting throughout the state of California with, gosh, I think we're approaching 11 sites that'll be open next
Congrats.
year. Australia has half the population of California and has, I think, 160, 180 sites and has tremendous support across the spectrum because youth mental health is so valued and important. There's been a crisis declared by the American Psychiatric Association, American Academy of Child and Adolescent Psychiatrists, and the American Academy of Pediatricians, Children's Hospital Association of
And the
Youth
World
Mental
Health
Health.
Organization
Yeah,
just
yeah.
reading about their statements. Yeah.
And can imagine we can work toward addressing that here with prevention and early intervention before the crisis and before much more intensive resources need to be applied, and like to think helping folks earlier can stave off some of the most harmful effects later on, as we know from adverse childhood experiences research,
Early psychosis research. Yeah.
early psychosis research, which I've watched from nearby in the Center for Youth Mental Health and Dr. Adelsheim's work, expanding that throughout the US. Um, there's just so much going on and so much that needs to be done, and a lot of partnership development, collaboration, coordination between different institutes, agencies, governmental bodies, communities, and having more community voice, youth voice, helping inform and direct what's needed and helpful rather than suits telling folks this is what's good for you.
Yeah. Yeah, definitely. I'm remembering that at one point we all met in Berkeley to create this alliance, the RUMBA, Rural Mental Behavioral Health Alliance. And it didn't go anywhere, but that's not to say it wasn't a good idea. But I think it was to determine how we might expand more psychiatry uh, residency programs, possibly research. I don't know.
I
It was
think,
fun.
yeah, it was. And I really love the acronym. I really wish it could go places. And I think that speaks to the lack of resources in terms of coordinating and optimizing the professional expertise and the learning so that folks aren't, say, duplicating um, efforts across the bay for particular training. Um, and so that people in Palo Alto, in Berkeley, or Chico, or elsewhere can have access to real-time best evidence education for their practice. Oh, hopefully lessen the burden for everybody in these training programs to have something consolidated and facilitate greater communication between different folks who are otherwise working in parallel or might not cross paths, even though in the same geographic area.
Yeah. Yeah. Always good. Always
Yeah.
good to talk to you. And I think that's the space that we live in, which is there's always more problems to solve. And how can we do that? It's a beautiful thing.
Yeah. I sometimes feel the weight of it, and some days, especially those I could chat with you, I feel like there's so much more that we can accomplish, and really appreciate the work that you're continuing to do and making the imagined possible.
Well, thank you. Yeah, and my husband and I were just talking about that, where I don't really look at something as like just because this is hard or maybe not likely doesn't mean that it can't be done. I don't know.
Yes, likewise, like I'm imagining from public health days, probably in the 1920s, folks had the opinion smallpox, eliminate smallpox.
Right?
That's too hard. And if a lot of people didn't have the belief or effort or try, it wouldn't have happened. But doesn't mean we shouldn't, or at least can't brainstorm strategies and, I don't know, reduce. Yeah, keep that up. And if we happen to eradicate that or other things, awesome. But not accept it as a cost of living. That, yeah, doesn't feel right.
Well, if I could write you a check for 150 million to start a medical school in Wyoming,
Mm-mm.
I would.
Oh, well, thank you. I don't know if I'd be best equipped for that, but maybe could forward it to the person who would be. Yeah. Thanks for having me. Sorry aren't able to chat more, but maybe at a different time can have me back if it's helpful.
Always. You're always welcome back. All right. Well, happy holidays.
Thanks, you too, Kristy.
Thanks so much.
Lost my sense of humor, I've gone down to Fontanelle. Hovercrafts, blow up kayaks would have helped with